All right, welcome to class. My name is Andrew Fidino. I'm a flight paramedic. I've been flying critical care for about 5 years now. I have about 10 years of firefighter paramedic experience. So today's lecture is called R&R, which is recruitment and retention. So you all are aspiring to be flight nurses, flight paramedics, or just interested in critical care. So with this topic today, we're going to talk about maximizing oxygenation through practical education. So you all have balloons. So first things first, let's grab your balloon and we're going to talk about kind of what's going on with it. This balloon is going to represent what your lung is doing. And I'm going to give you one specific example that you're going to notice through our practical education. So question is how do we know that we are optimizing alveolar surface area for maximal gas diffusion? So with your balloon, go ahead and start blowing it up. And as you start blowing it up, notice that the very beginning of when you start to blow it up is the hardest, right? So as you start to blow it up, that's called the critical opening pressure. Once you get past that critical opening pressure, yeah, the balloons are good. Once you get past that critical opening pressure with what's known as your driving pressure, the lungs expand, the balloon expands. But until you reach that point, it's kind of difficult to get that balloon going. So with that being said, your lungs, very similar in nature to that. So that's something you're going to want to remember. So the answer to how we increase that alveolar surface area is to perform a recruitment maneuver. So I'm going to teach you one really basic yet fantastic way to perform a recruitment maneuver. So this is the Ravel ventilator, one of the most popular ventilators, as you guys know, and this is how to perform that recruitment maneuver. So step one, you're going to want to set your PEEP at 5. And that's intrinsically, when the patient is on a ventilator, that's typically what is set as a good benchmark just to start. That's a good place to go. Physiologically, in our lungs currently, without us being on ventilators, we tend to be at about a PEEP of 5 anyway. So we're really just placing the patient at where they typically are anyways. So from there, to expand those alveoli, first things first, we're going to check and document a static compliance, a C-stat. Next, we're going to increase the PEEP by 2. Okay? So now we are up to 7. We started at 5, we increased it by 2, so now we're at 7. We leave it there for 2 minutes, and 2 minutes later, we're going to recheck our static compliance. We're going to find that value. If it's now higher, we're going to add another 2 of PEEP, and the process continues. We're going to continue the process of plus 2 of PEEP for 2 minutes until there's no more gain in static compliance. So it's hard to wrap your brains around right now, but I'm going to break it down for you so that we can definitely make sure we get it. So if you can just remember 2 for 2, what I mean by that is 2 for 2 is 2 of PEEP for 2 minutes, 2 of PEEP for 2 minutes, 2 of PEEP for 2 minutes, just like that over and over again, until the time you don't have an increase in static compliance. So let's see if we can try it out. So here is your patient. We set our PEEP at 5 because that's a good benchmark where we're starting at, and we have a static compliance of 28. We're just going to write that down. Just keep a little scrap paper, piece of tape with you. We're at 28 right now. So we give it 2 of PEEP because we're going to try this recruitment maneuver. So now we're up to 7. Leave it for 2 minutes, right? Just like we do. Now we have a static compliance of 42, which is up from 28, right? So what do? Yep, we increased the PEEP by 2, so we were at 7, now we go to 9. And we let it sit for 2 minutes again. Now we are at a static compliance of 54. Is that an increase? Mm-hmm. Yep, so what do?
Add 2.
Add 2, yep, add 2 PEEP. So we were at 9, now we are at 11. And we let it sit for 2 minutes, and now we are at a static compliance of 64. Increase?
Yes.
So what do?
Add 2.
Add 2. So we were from 11, we go up to 13. We let it sit for how many minutes?
2.
2, yep. Let it sit for 2 minutes, now we are at a static compliance of 62. So we have had a decrease in static compliance, which means that we were optimally finding our correct level of PEEP at the 11 mark. So what do we got to do? We stop. Okay, stop right there. We are not happy at 13. We actually want to go back to our level of 11. We had the most compliance with that patient at that time, okay? I also want to add a special note that when you check your static compliances, you want to check 3 in a row. They're very short, just takes about a half a second or a second for each of them. As long as your patient's not coughing or gagging or needs to be suctioned, anything like that, do 3 in a row. Take that value, let's say you have 30, 31, and 32 for all your, take the average. So you'd be at 31 at that point. Take the average. You don't want to get one-offs. You don't want to make changes to your patient based upon maybe a one-off. So I always like to take some serial static compliances. So that's your recruitment maneuvers. Really simple and truthfully very effective. And you always want to make sure your PEEP is at a great level because that's something, especially in regards to ARDS patients, that we're going to want to keep in mind. So after we have our PEEP managed and it's set at a good spot, doesn't mean we're done. We need to fall back onto ongoing respiratory assessments. These are things that we need to do on all of our respiratory patients, inpatients on the ventilator. It's just good things to know for our patient care. So here's some basic values. Your PIPs, your positive inspiratory pressures, you always want to have below 40. Anything above that, you really get into increasing the likelihood of barotrauma. You don't want any of that or ventilator-induced injuries. Next, your plateau pressures, your P-plats. You also get a P-plat every single time you check your static compliance. Those are also nice. Write both down as you get your static compliance. You want to keep that below 30. Okay, so for the similar reason, P-plat has more to do with oxygenation though. Your end-tidal CO2, you want to have between 35 and 45, obviously different on different patients, but these are just basic values that we want to maintain between. You also want to remember that your end-tidal CO2 is your lowest value of carbon dioxide. Your blood gas with your CO2 is going to be that level of end-tidal CO2 or greater. Your end-tidal will always be your lowest carbon dioxide value, okay? Your driving pressure. Now, driving pressure, as we talked about originally, is a combination formula of your P-plat minus your PEEP. And so if you take your P-plat, which we have, minus our PEEP, you want to make sure that that number is less than 15. If it's 15 or greater, it increases your likelihood of morbidity and mortality, improper patient outcomes. So we want to make sure that we keep our eye on that as well. As we're getting further on in our patient care, we get to fine-tune our ventilator. So in respiratory therapy, in the ICU, medical floors where there's some ventilated patients, these are things that you want to really fine-tune in a long-term ventilated patient. So one thing that we can do is utilize a formula called a time constant. And the time constant is a formula where we take our resistance minus our flow, multiply it by our time constant. So what do I mean by that? It's a way that you can finely tune your I to E ratio. Okay, we've been taught about I to E's with pediatric patients, adult patients, obstructed patients, 1 to 1, 1 to 2, 1 to 4, those types of things. But specifically with these patients, there's ways that we can calculate exactly what our I to E ratio needs to be, keeping in mind with our tidal volumes and minute volumes as well. So we can calculate our resistance, which is just a formula of our PIPs minus our plats. That shows our resistance, okay? And then our flow. And our flow on all of our ventilators comes back to us in liters per minute. Specifically with this calculation, we need to utilize liters per second. All you need to do is take your value on your ventilator for liters per minute divided by 60. So we can use it for this formula. We then multiply it by our time constant, which you can see here is 0.3. 0.3 is optimized for maximal and efficient ventilation, whether it's inspiration or expiration. You have 95% volume, either in or out, by utilizing a time constant of 3. So after all that time constant is utilized, it comes up with your expiration time, okay? So you can calculate exactly what your E needs to be, and then you can balance that out with your I to E ratio. We're going to talk more specifically about that further on in another lecture, but I just want to give you a brief little overview right now. This is something that I always want everybody to remember. It's very important for respiratory patients, let alone any patient population. Changes in patient status, hemodynamics, pharmacology, any medications you give, any treatments, they all have an effect on oxygen demand and respiratory status, okay? The whole body is all working together. And as you do one thing, change one thing, see one thing, another part of your body is going to balance out. It always wants to just equalize. After you change anything on that patient or any change, you have to remeasure those respiratory values, okay? And that's where you can find yourself. fine-tuning patients, okay? So here's the question. Can I do more to ensure maximal oxygenation? Is there more to do? And the answer is yes, absolutely. Okay, do you want to be a paramedic not in my county? Or do you want to, as the purpose of this course, obtain that FPC or to be a registered flight nurse? So what are some things that we can do? Knowledge is power. So in this next little section, these are just fine-tuned points, really basic points at the same time, where you can really maximize the oxygenation of your patient by utilizing these things. So number one, knowledge is power. Number two, see the aforementioned line, because knowledge is power. And line three, copy and paste number one, knowledge is power. You get my point. All these things that we're learning are going to be really important for your respiratory patients. So optimization techniques. Positioning and body habitus. So as you sit up your patient, any position you have your patient in, keep in mind that that either takes away pressure on their thoracic cavity or applies more. Oftentimes with our bariatric patients, we have them lying flat on spine boards, things like that, or just lying flat in general. All that chest weight presses down on that thoracic cavity, okay? And it's gonna decrease the likelihood of increasing volume of their lungs. So we wanna keep that in mind. Oftentimes, patients that I can't sit up or patients who have an increased BMI, I'll increase their PEEP just by a little bit to help offset that. First things first, I can just sit them up if I can and completely not have to worry about increasing my PEEP at that point. And body habitus, the shape of the patient. Are they tall and lanky? Are they short and squatty, Santa Claus type people? That type of large belly or even pregnant patients. That diaphragm gets pressed up on, okay? And as that gets pressed up on, the ability for your lungs to expand diminishes, okay? So there's basic things that you can do to really optimize oxygenation. PEEP valves on your BVMs. I feel as if this should almost be a law. Anytime that you're using a bag valve mask, it's always a good thing to just throw on a little bit of PEEP, okay? That's super and quick little point there. Lower your oxygen demand, and this one actually goes along with the next point here is decrease anxiety. Those two things are hand in hand. As you decrease anxiety, decrease pain, you're also lowering your oxygen demand. From your lungs to your heart, to wherever you need it, you don't need as much oxygen when you have less anxiety. So something that we do quite often in critical care medicine for these respiratory patients to achieve both of these things is utilizing ketamine. Okay, ketamine is a fantastic drug that we use. It's a potent beta agonist, so it's going to increase your ability to dilate your bronchioles. Okay, and it's also going to decrease your anxiety. Potent bronchodilator. Decompress the stomach with an OG or an NG. For the same theory as the diaphragm pushing up, that stomach pushing up is gonna take away some of your volume from your lungs. So go ahead and, if you're intubating, also just throw in an OG tube at the same time, even with your laryngoscope still in there. Just throw in an OG, decompress the stomach, check that box, move on. This is something that I call the super plug, and it's gonna make you a hero, okay? So, it's 2 NPAs and an OPA, okay? So the reason why I'm calling this a super plug is because you fill up both nares and you also throw in an OPA. They have 1, 2, 3 an oral adjunct and 2 nasal adjuncts. Each adjunct serves as a 33% gain in airflow. So we almost have 100% airflow with just throwing in that super plug. I recall the first time I did that, I felt a little bit weird, but then you get to thinking about it. Is there anything wrong with that? If they obviously don't have a basal skull fracture, any contraindications, go ahead and do that. The nurses might look at you goofy at the hospital, but it's just because they haven't seen something so cool yet. So give it a shot, try it out. 2 rescuer bagging. Now this is very important. I call them the airway team. We all think that we're fantastic baggers, okay? We've all been doing it for years. All think that we have a good hang of it, but truthfully, when studies come to show, we're just not that fantastic at it. And as we're in a situation where our patient stops breathing, whether it's elective for a procedure at the hospital, or they have some sort of physiology that makes them stop breathing, or performing an RSI, 1 rescuer bag just isn't sufficient enough. So my airway team, one holds the mask seal, okay? And we utilize a TE approach. We'll show you that later. And then the other one just bags. They stay focused on that airway task. They are not assigned to control medications. They're not assigned to keep track of time. They are the airway team. And that's something I'm a big proponent of, okay? And last but not least, you want to ensure adequate perfusion. And the best way that we can really truthfully say that we're perfusing well is to calculate our MAPs. So a MAP greater than 65, which is generally a systolic of 90. Now, keeping in mind that the MAP, which as you all know, is your systolic plus 2 times the diastolic divided by 3, okay? You all know that. Oftentimes it just calculates itself on our monitors, if by chance you're without. Good thing to remember that. With a MAP of greater than 65, you can ensure proper cerebral perfusion, okay? So if you're getting that, you're pretty much good to go, okay? With that being said, I hope that covers the R&R section of this segment, and I thank you guys so much for being here.
Thank you.